So we're going to talk about an abdominal aortic aneurysm, or AAA. So mortality-wise, 50% get to hospital, and the rest die before they get to hospital. And of that, 50% don't get to theatre. Okay, so what are the risk factors for AAA? Well, they are being a male, being aged over 65, smoking, hypertension, ischemic heart disease, cerebral vascular disease, or genetic issues such as Marfan's or Ehlers-Danlos. So what are the risk factors for AAA? They are being a male, being over 65, being a smoker, having hypertension, having ischemic heart disease, having cerebral vascular disease, and having genetic diseases or connective tissue diseases such as Marfan's or Ehlers-Danlos syndrome. How does it present? So the classic triad is pain, usually in the back, pulsatile mass, and signs of circulatory compromise. So the triad is pain in the back, a pulsatile mass, and circulatory compromise. But you may get other things: renal colic type pain, radiation to the legs, severe chronic back pain in a contained rupture, and transient lower limb paralysis. So you have a triad of pain, circulatory compromise, and a pulsatile abdominal mass. You may also have GI hemorrhage, which may raise the issue of an aortoenteric fistula. So what are the treatment options? Well, A, B, C, D, E. This is an emergency, and they need to go to theatre as soon as possible. And you don't delay the surgery in order to do investigations such as scanning. So, first of all, we'll assume A and B have been dealt with. So A would be to assume that the airway is okay until you go to theatre, and B would be to give oxygen. So C is all about resuscitation. So you need 2 large bore cannula, and you need pumps or rapid infusers ready, and you need to cross match either for 6 units or for a major hemorrhage protocol. You want a blood pressure of 90. Okay, and you'll need to give painkillers as well, so something maybe short acting like fentanyl or morphine. might also want to consider doing some investigations quickly, so FBC, U&D, coag, gas, lactate, an ECG, just in case there's a differential diagnosis such as an MI. You might be able to do some quick imaging and then get to theatre. You can also consider a ROTEM or a TEG. But the main point is that you need to get to theatre as quickly as possible. And how do you treat it in theatre? Well, you can do an open repair or you can do an EVAR. And there is some evidence that these have better mortality rates, but this is not definitive yet. So what imaging might you want to use? Well, a CT is good if you're uncertain and can give detail of the aneurysm and can confirm the rupture and look at the aortic wall. But downsides, if they're hemodynamically unstable, then you're not going to do this, and it delays surgery. And giving contrast may damage the kidneys. You could do an ultrasound or a fast scan. And this is rapid and it's bedside, and it tells us you can see the aneurysm, but more often you can see free fluid. Problem is, it's not perfect. There's an MRI. Now the disadvantage is that this takes a long time. It costs a lot. But it is highly specific and sensitive. You don't give any contrast, and you can get tissue characterization. Okay. So, how do we prognosticate? Well, there's two ways. There's the Glasgow aneurysm score, and there's the Hardman index. And the Glasgow score is made up of 5 variables: your age, the presence of shock, the presence of heart disease, the presence of cerebrovascular disease, and the presence of renal disease, which they define as a urea greater than 20 or a creatinine greater than 150. And these all are worth various points. The presence of shock is 17 points, myocardial disease 7, cerebrovascular disease 10, renal 14, and age, your number of points is equal to your years. The Hardman index is an age greater than 76, creatinine greater than 190, a hemoglobin of less than 90, an ischemic ECG, and whether or not they lost consciousness. There's other ways you could prognosticate. For example, possum score, and there is a vascular specific possum score, You could think about Apache 2. But there are, like I say, these two are the far more aneurysm specific tests. So, complications. Well, we can think of these as non-graft and graft, and we can think of them as early or late. So non-graft, well, you're going to give them a massive transfusion. There's a risk of distal emboli and ischemia of branches such as AKI and pancreatitis, and you may get an endoleak. Late complications are infections, the graft being occluded, the presence of an aorto-enteric fistula, and a pseudoaneurysm at the anastomosis. So sorry, these are the graft-related ones. The non-graft related ones are MI, renal failure, paraplegia, hepatic dysfunction, HAP or VAP, ARDS, compartment syndrome, and ileus, and late, or they may have a long respiratory wean, a small bowel obstruction, hernia, DVT or PE, and impaired sexual function. So when do we intervene? Well, we should be doing elective repairs if you're male with an aneurysm of greater than 5.5, or female 5, or growth greater than 1 centimetre per year. You can do abdominal ultrasound as monitoring. So when might you use a spinal drain? Well, first of all, they are to reduce CSF pressure after an EVAR, because they are at risk of cord ischemia, and you can use it as a rescue therapy if they do get paraplegia. Other things are to reduce ICP in neurosurgery, to get CSF results for chemistry, and temporary drainage in patients with shunts. So what are the indications for a spinal drain? Well, it's to reduce the cerebral fluid pressure after an EVAR where patients are considered at particular risk of cord ischemia, and as a rescue therapy in paraplegia. You can also use it to lower the ICP in neurosurgery for CSF sampling, and as a temporary drain for when the shunt isn't working. How do they work? Well, the cord perfusion pressure is the MAP minus the CSF pressure. So if this rises, then cord perfusion falls. So if you drain it off, that will fall and that will rise. So you've got a percutaneous catheter in the subarachnoid space. And decrease the CSF pressure. Now, what are the contraindications to this? Well, anticoagulation and bleeding, and it's also not recommended in a non-communicating hydrocephalus if there's a large intracranial mass lesion, or if there's infection of the skin, bone, subcut tissue surrounding the space. So the contraindications of spinal drain is a patient who is on anticoagulation and a patient who has a bleeding diathesis, and you should also try and avoid it in a non-communicating hydrocephalus, a large intracranial mass, or if there's infection overlying the site.